Welcome back to the Dr. Greg Jones Optimization Academy podcast. In today's episode, I am honored to be joined by one of the most respected pioneers in naturopathic medicine and women's health. Dr. Tori Hudson is a naturopathic physician with over 4 decades of clinical experience and leadership. She's a renowned speaker, best-selling author, educator, researcher, and a clinician who has shaped the field of integrative women's health for generations. She's a medical director of a Women's Time in Portland, co-owner of Vitanica, an amazing supplement company specializing in women's health, and the program director of the Institute of Women's Health and Integrative Medicine. In this episode, we're going to take a 2-part journey. In part 1, we're going to talk about what women in their 20s to 40s should know about hormonal health, even if they're not even experiencing any thoughts about menopause yet, or even thinking about it. We'll also unpack the impact, like that rhyme, of long-term birth control use, signs of hormonal imbalance, and what can be done nutritionally and supplementally to restore hormonal balance. Then in part 2, we're going to transition to menopause and the menopause journey, how hormones shift when to consider natural versus prescription therapies, and what daily habits and supplements should actually move the needle. So whether you're in your 30s, 40s, 50s, or 60s, or beyond, this conversation is full of practical, compassionate, and science-based insights. Let's get to it. Dr. Hudson, welcome to the show.
Dr. Greg Jones, thank you for having me.
All right, now that we've got the professionalism out of the way, you can call me Greg and I'll call you Tori. So we had to get that out of the way, so to speak, and all that good stuff. So welcome to the show, and I'm really happy that you're here. And again, and as a doc, I've been a doc for 8 years now, and we've known about you since school. It's like Tori Hudson, she wrote the book. She literally wrote the book. And, the Vitanica supplements and all that. So it's an honor to have you on the show. And so I want to talk about your journey, because you've been at this for over 4 decades.
41 years this summer. Yeah.
Oh my God.
Yeah, still kicking.
Oh, we appreciate it. And part of that journey has been helping women understand their hormones through every stage of life. So tell me about your journey, how you got into naturopathic medicine, and how that got you into women's health and even starting Vitanica.
Okay.
Yeah.
For me, I'm 73 and I graduated from high school in 1970. So the reason why I mentioned that is because 1970, we were presented with many new ways of thinking and being. And I feel like at that young age of 18, there was 18 and early 20s, this sort of convergence of being exposed to, at the time, it was called the Back to the Land movement, but it was really about sustainable living, growing your own food, living on land and being able to support yourself. So it was a convergence of that and what's called the self-help movement for women, like learning about their bodies. Our Bodies Ourselves was a big book about doing self-exams and such. And then the third thing was the first, I believe, Earth Day. And so consciousness, awareness about the environment. And then the fourth thing was feminism, really. And so those things all were influenced my changing, being introduced to natural foods and all these things that I just mentioned, which ultimately led to naturopathic medicine, frankly. And for me, naturopathic medicine is, it's a way of life. It's not just a way of practicing. And that's, to me, what's beautiful about this job and this career and this life is the sort of like the life one lives, how one believes, and the job one has is sort of all one thing. And I think that's a true privilege that I have as a naturopathic physician. And I went to college right after high school, and then I was a college sort of dropout midway because of all these things that were going on in the world. And then I found my way back because during that journey there was living rurally, growing food, learning about herbs on my own, and then it just sort of became, wow, I hunger for this knowledge, and I can't just teaching myself is not enough. And then I had certain kind of key events where I met people that said, oh, wow, there is this thing called naturopathic medicine. At that time, it was a night school in Seattle taught by Dr. Bastyr and one other. And so I did not go to that night school, but I went as a visitor. A friend took me, said, look at this. And I sat in there. I was like, wow, this is really a thing. A small thing, but it's a thing. And then, so I knew then that there was this career called naturopathic medicine. And then I found my way back to that within a couple years, and there was a school in Portland. And so I actually had to go back to college to finish my pre-med and requisites and such to then go to school. And I started in 1980 and finished in 1984. And, there's some of those things in life where you look back like, wow, so how did I meet that person that led to this, that led to that? There's just sort of those moments, and some of them magical and some of them prophetic and some of them so influential. And it's sort of a reminder of, oh, pay attention. Pay attention to who you meet and the moment that is here, and try to understand the purpose of the moment.
And I feel like I'm guilty of that too. I feel like it's hard when you're on the go and the wheels are turning to stop and appreciate the journey, because the car doesn't stop, and you're just like, oh man, like how did I do this? And I can't believe I met this person, and you just kind of keep going. I think it's good to kind of sit back and reflect upon it every now and then, because the journey is, man, you get one chance, man. You get one chance. And telling you, my memory ain't what it used to be. It's still good, but every now and then I'm just like, man, like, oh, how did that happen? And so I appreciate that. Well, I'm glad, that you went back and found this path, because you've been impactful for so many of us doctors out here practicing medicine, especially getting into women's health. And so, good segues. I want to set the stage here, because usually when we think women's hormones, we're usually thinking menopause, perimenopause. And that, to me, is only the first part of the story, second half of the story, one part of the story, second half of the story. But in that first part, and I guess there's this, and I don't know if women are like guys, like we're young, we're bulletproof. It's like nothing. Yeah, nothing. You don't even think about your hormones, just going. You got all these hormones, you're flowing, you do all these hormonal things. You got the acne, you do all these things here, and then you get older and your hormones are raging out of control. But for women, what are some of the common concerns that younger women will experience or deal with even before they get towards perimenopause?
Yeah, it kind of starts with PMS and or menstrual cramps and or irregular menstrual cycles. It kind of like it's one or more of those that like brings a girl, a young woman to, oh, I don't feel good, and I don't feel good in these kinds of ways, and they try to help themselves or they try to find help. And then it kind of moves into for years it's all of that. At some point then there's fertility related things, and then pregnancy related things for many women, and postpartum things related for some women. That's sort of the bulk of it. And then unfortunately, along the way, women might have, ovarian cysts or endometriosis or uterine fibroids or polycystic ovary syndrome. But the big bulk in the sort of teens, 20s, and 30s is the PMS, irregular abnormal uterine bleeding of some kind, and menstrual cramps. And of course, not everybody has those. But I think this is a different experience for women than for boys and men, is there's this sort of monthly reminder of, and or monthly problem that might be, one day, it might be a few days, it might be half the month. And of course, as naturopathic physicians and other providers, we're going to tend to see the girls and young women that are having more than a little bit of a problem with it,
Mhm.
and they need help.
So when they go seek that help, and this is what I see in a lot of those younger women that come to the clinic, it's the kind of go-to for a lot of those PMS symptoms and hormonal symptoms is a birth control pill.
Mm-hmm.
And it seems like, hey, you've got acne, here's birth control. You're
Yeah.
having certain hormonal symptoms, excessive menstrual bleeding, here's a birth control pill.
Yeah.
But I read this somewhere or heard it at a presentation, and I was like, oh, man, this is it. And the guy was talking, he's like, yeah, it was the single biggest non-controlled study in the history of the world is birth control pills. Because he's like, well, you start birth control when they first created these pills, and it's like, here you go, but it never looked at the long-term kind of effects of it. And so now we're realizing that birth control pills do damage to the microbiome and increase the risk of depression and a host of other things. From what your experience, how, and a lot of times they're put on birth control for 10, 15, 20 years plus. They're older women come to my clinic, even in their 40s, still on the birth control pill. How does that affect their hormones and their gut and overall health, especially being on it for such a long period of time?
Well, I want to go back and address this in a little bit different way, in that it's, to me, a mistake to prescribe anything, even an herb, even a nutrient, even an over-the-counter, let alone a prescription, without knowing what is going on. So, meaning, you have acne, let's say cyclic acne. Yes, birth control pills are one method, but might there the biggest thing that one of the bigger things that might be underlying that is polycystic ovarian syndrome. So if you just prescribe the pill, you miss the opportunity, or you just prescribe some cleanse or some diet or some nutrient or some topical, no matter what, natural or conventional, if you just look at the acne, you miss the opportunity, like, oh, this woman might have polycystic ovarian syndrome, or might have hyperandrogenism due to some other cause. Irregular bleeding, definitely don't just give chaste tree or a birth control pill or cyclic progesterone before coming to some logical clinical assessment of what is the cause of this woman's abnormal uterine bleeding. So that, to me, across the board, and natural minded physicians are just as vulnerable to making that error as is someone who just prescribes birth control pills. The other thing I want to say is birth control pills have been transformative to women's lives in the history of women. And so we want to give them respect for what they have offered women in terms of contraception. And but also, birth control pills have a lot of other benefits. They can, if you have a family history of ovarian cancer, you take birth control pills for at least 5 years, you reduce your risk of ovarian cancer by 50%. Um, uh, there's and having let's say you don't have a period, let's say you're premature menopause, it's been determined, why did you stop bleeding? And again, that's another one that definitely deserves a proper evaluation. But let's say the proper evaluation leads to, oh, she's 35, she stopped bleeding because she has premature menopause or premature ovarian insufficiency. That person needs hormones. They need estrogen, whether it's a birth control pill or a certain dose of menopausal estrogen. The birth control pill is great because it's easy, it's available, it's affordable for most people. And this way, this young woman who's got premature menopause won't get osteoporosis, or now it's a preventive medicine. So she doesn't get osteoporosis and heart disease and premature brain aging. So there's so many good things to be said about birth control pills. And to me, the benefits far outweigh the risks. And of course, there's women that shouldn't get an oral birth control pill, like a woman that has a migraine with aura, for example, or a woman who has a history of a breast cancer, or a woman that had a clot or a DVT. There's contraindications. But I feel like as a contraceptive method, I present her if she needs contraception, here's the options and here's the benefit, here's the pluses and the minuses of each. And if she chooses birth control pills, okay, then it's my job okay, now how can I minimize any downside, which I consider small for most women, and go from there, whether that's a probiotic or some vitamin that has folic acid in it, or things. I feel like we can do something in tandem with the birth control pill. But I know for alternative, naturopathic functional medicine practitioners, I feel like the two drugs that get the biggest bad rap are birth control pills and statins. And I feel like we got to really do a little gut check on both of these things and really reassess, and be a bit more, be quite a bit more, what's the word? Studious, but discerning about who really is going to have great benefit. And the same with statins. You've had a cardiac event already and your LDL is, 250. Yes, I'm going to do this diet and exercise and natural medicine, but you should go on a statin. And then if we have some problems from the statin, okay, well, then we can deal with that.
No, and I appreciate that too, yeah.
Sometimes I think we call out, oh, she went on birth control pills, and once she stopped, all these bad things happened. And sort of blaming the birth control pill that they caused those problems. That is likely not the case. You stop birth control pill and you have acne, you had an underlying cause that has been brewing, like probably PCOS, that the birth control pills were actually effectively managing, and now you went off, and now here it is. Here's the problem has emerged and it has evolved, during this time, and here it is. That doesn't mean birth control pills are the answer to PCOS. I'm just kind of giving an example, because actually natural medicine has very strong options for PCOS. Or you go off your birth control pills and you're not getting your period. Well, actually, permanent amenorrhea is not caused by birth control pills. It's that that's an example where she had an underlying cause of not having a period that was maybe never assessed and determined. She went on birth control pills, so she had a monthly cycle, and now she's off the pill, and here the problem still is. It's not that the birth control pill caused that, it's that she had underlying amenorrhea, and now we have to revisit that.
Oh. No, I appreciate that, because again, and it's all about, like, I always say, like, we tend to, they say you're the average of the 5 people you're around the most, and sometimes as a doc, you're average of the 5 or 6 doctors that teach you, and then you end up being like, and so I've had my pitchfork and my torches for birth control pills for too long.
Well, like I said, that's funny that you mentioned that. Like I said, it's a bias, I think, that's been around birth control pills and statins, and I think it's unfair. And we can, any concern we have about consequences of birth control pills, I feel like we can mitigate those with, fiber or probiotics or fish oils or yada, yada, yada.
Okay. And that's actually a good segue here, because eventually some women do want to come off the pill.
Yeah.
And understanding, like, hey, understand if there was underlying PCOS or any type of hormone dysfunction, addressing that. But And I even looked in one of the supplements you guys have with Vitanic. I believe it's the Fem Rebalance, and it's
Fem
like
rebalance.
Rebalance is a good one that's recommended for women coming off of the birth control pill to help kind of rebalance.
Yeah.
So, what are some of the things that women coming off the pill when it comes to kind of getting rebalanced, so to speak, should be concerned about or looking at if they're deciding to stop?
So let's say she didn't have an underlying condition and she just was using it for contraception. So you can, and she's been on cyclic birth control pills. And so she's had a monthly cycle. Um, and she goes off the pill, like you mentioned. Um, how long it might take up to, I mean, usually she'll have a period within 2 to 6 weeks, let's say. But it can take up to, typically the maximum is 3 months. And then what if you have someone that is outside that window? Um, then I would be thinking, okay, there might have been an underlying cause that didn't ever get diagnosed. And so now, but I would give it 3 months, and you can use something like Fem Rebalance that has chaste tree and maca and black cohosh and rhodiola and some other things in it to try to basically, because the the hypothalamic pituitary ovarian axis has been, kind of overrided with the birth control pill. So it's logical that it's going to take a while for the symphony to get back up and running. And so that's the advantage of some of these plants that Vitex promotes ovulation, maca kind of promotes the whole orchestration. So it's I think is a nice idea to put someone on is right when they go off. But if they have gone 3 months and it's still not back, then I would start to think, okay, I'm going to start the evaluation of what might be going on.
Okay. Gotcha. All right. And then the next one is so a lot of women are already hearing about, younger women as well are hearing about perimenopause. And
Mhm.
so that kind of transitional period before menopause, how early can that actually start? And what are some of the biggest misconceptions about starting or entering perimenopause?
Well, I mean, it can start prematurely. Uh, the process can start, um, anytime after age, 18, frankly, or, 16. Every time after she started menses, she could get premature perimenopause or menopause. If it starts to happen before age 40, meaning less regular menses, hot flashes, night sweats, we don't want her to stop having a period before age 40. That's called premature menopause. Um, and just because she's starting to have a little bit of irregularity doesn't mean her periods are going to stop. But I would take that opportunity to see if I could prolong her ovarian function, basically. And then so premature is before age 40, and early is between 40 and 45. So if she actually stops because of menopause, and we have to determine that, before age 40 or between 40 and 45, the standard of care guidelines is to start her on certain doses of estrogen and progestogens because she is going to be that much many more years without the protections of bones, brain, heart, and everything else. But those three are the big three. Um, it's Other than that, I mean, women can start to have symptoms easily 4 to 7 years before their last menstrual period. But again, we have to make sure we don't sort of we don't want to make assumptions just because whether she's 38 or 48, just because she's missed a period or two doesn't mean it's perimenopause. We have to go through the process of what could it be? Is it thyroid? Is it prolactin? Is it, you know, Is it PCOS? Is it hypothalamic amenorrhea? Is it menopause? And there's an algorithm of tests to do to go through that process.
So a lot of times when women appear to clinic or come to clinic with those kind of perimenopause symptoms, some of the more common ones that we're seeing is low libido, fatigue, mood swings, depressed mood, weight gain. And a lot of these really kind of fall into that low testosterone kind of category. And so is there in your opinion, is there like kind of and I hit, it's like Elvis leaving the building where testosterone goes first, and then estrogen, and then progesterone, or is it as simple as that, or is it more of every woman's different and these levels are going to fluctuate depending on the female and her lifestyle and these other factors that go into it?
It's very individual. And I would
Okay.
say, I think this is another area, you and I might differ, but this is another area where I think that naturopathic and functional medicine docs are sort of narrowing the lens. Oh, it's testosterone. And even if they're there is actually no value of testosterone that is related to any there is no low value related to any particular symptom. There elevated values related to acne, hirsutism, PCOS, but there is no value in the normal range or lower than the normal range that where we could say, oh, that is the cause of your low libido, or that is the cause of your fatigue, or that is the cause of your muscle weakness. There's no data on that. To the standard of care guidelines from about at least 6, if not close to 10, international endocrine menopause societies, they have a really nice document. The only standard of care guidelines for testosterone prescribing is low libido in women. Now, that doesn't mean that has to be the end of the story, because, we as alternative providers are used to kind of the edges and the gray zones of things. But I think we have to be careful that, the cause of you're 45, the cause of your fatigue is low testosterone. I could not say that. The cause of her fatigue is probably much more likely, sleep, stress, maybe low iron and thyroid. That's going to kind of be or depression, and that's going to be the bulk of it. But I think it's really misleading to say, this number of the testosterone is related to this symptom. The main reason, again, from these guidelines, the main reason to test testosterone is if you're considering prescribing it, and so you don't overdose the person, because you don't want her to be higher than the reference range, because that can increase her risk of perhaps breast cancer, perhaps heart disease, let alone perhaps some side effects. But it's remarkable. I've had women, to me, the maximum dose of testosterone for a postmenopausal woman who wants to maintain her femaleness is 10 milligrams a day. So I'm not going to go over that. And so the purpose of the test is to give me comfort that I'm not going to go over that. But I've had women have acne at 1 milligram. And most women at 10 milligram never get acne. So it's very, very individual.
Yeah, indeed. And again, and I agree with you there. It's not just testosterone only. It's like, I like to say that we don't practice like a men's health clinic, just giving people testosterone shots in the left butt cheek and say, get out of here and we'll do the right next week. It's more of like, what else is going on, right?
Yeah.
Because it's cortisol, it's sleep, it's stress, it's thyroid.
Yeah.
It could be micronutrient deficiencies. Like, hey, you got a B12 of 300, like that might have something to do with it.
Yeah.
Or maybe you're just very, very sedentary and there's a lot of different, maybe you just, you start pulling the string and maybe you have like an MTHFR. There's so many factors that go into it. But when they start getting that later period in life, and again, the low libido is a big part of it.
Yeah.
But again, it's smarter than just saying, you have low libido. It must be the testosterone. There's so many other factors that go into it. And I think if we're being smart practitioners, we're looking at the whole picture of it and using it as a lever.
Depression, we're looking at the relationship, we're looking at basic fatigue. We're looking at it's painful sexual. It's painful. We got a letter. Or she has general pain. There's a lot of other things to look at.
No, and all that makes a ton of sense.
And we're in but we are in this like kind of hormone prescribing frenzy. I would say right now, and not just prescribing, but it seems I think it's unfortunate that, I mean, I think there's a plus and a minus to this heightened awareness about hormones. The plus is, yes, that lens and prescribing hormones can help a whole lot of women. But on the other hand, we don't want the message to be what's wrong with women is their hormones. Well, what's wrong with women is the world they're living in, and all the things that might mean in their life. They're a single parent and they got a full-time job and they got 2 kids at home, or there's this, let alone, environmental exposures, let alone they're anxious about the state of the world, let alone their finances. There's so many things. So I am kind of one right now in this moment of everything hormones is like, well, wait a minute,
Mm-hmm. Yeah, it's everywhere. It's everywhere. And there was a big hearing. I mean, it was about like 2 months ago. I forgot the lady's name. She was at the just basically going through some of the kind of
myths, yeah.
Myths and all this. So like, hey, this is not this, and this is how women have been helped by that. And I think that brought a lot of awareness because that had a lot of eyes on it recently. And I think being educated and being mindful of it. But again, I think it's smart not to just haphazardly prescribe, because there's no free lunch in medicine. Like when I give you something, something's got to give, or you got to take something. Yeah, and it's about minimizing the consequences and doing it a smart way, which is great. So, sorry, go ahead.
No, I just was going to take us off on another tangent, probably.
Huh. Tangents are good.
You're curious? Okay. Well, the other thing that kind of, I think, again, I mean, naturopathic, functional medicine, integrated medicine practitioners, I think want to do the right thing. I mean, all clinicians want to do the right thing. But one of the ways I feel like this road is taking us is contributing to not doing the right thing, which is all this hormone testing, all this hormone prescribing has an environmental impact. What are all the supplies that are used in all the different hormone tests? Those end up in the landfill, by the way. What are the devices that are used day after day, month after month to deliver the hormones? They end up in the landfill. What are all the personal protective equipment that compounding pharmacies have to use now? I mean, they have the amount of non-recyclable stuff they're having to use to keep compliant with the regulations is mind-blowing. So I feel like we should maybe kind of step up our game plan about what does do no harm mean. It doesn't mean just give out, test, give out, and the garbage ends up out of sight, out of mind. It's not really out of sight, and it certainly is going to have an impact somewhere, to some being, to some entity, to some plant life, to some waterway, to some airway. It all matters. Same with artificial intelligence. Don't get me on that.
Well, I got a tangent for you because I just saw this. And do you do IVs? It is IV therapy.
I personally don't, but someone else in our clinic does. Yeah.
So I was flying back from a conference and I get this article, and it was like, scientists find excessive amounts of microplastics coming from the IV bags. And I was like, are you shitting me right now? Because I kept thinking to myself, like, one thing that I get to help people with a lot is IVs, right? And it's just like, what do you do? Because let's just say, hypothetically, I can get glass IV bottles.
Uh-huh.
I still have plastic in the IV lines.
Right.
You know what I'm saying? I still have the when you draw the, your B12, your B complex, you're still drawing it
That's
into a
right.
plastic syringe. And I'm like,
That's
I can't
right.
get away.
I
I
know.
can't get away from this, and it's just like, oh, that hurt my heart. And I was like, well, so I guess we're gonna be detoxing. I guess we're gonna be detoxing using phosphatidylcholines and
Yeah.
saunas and
Well,
ozone, but it's
I'm
just like,
glad you're thinking about it, but also it's like just like, okay, I don't wanna abandon or minimize the basic conversations and advice. I mean, I'm not saying we're all gonna be practicing nature cure at all. I'm not that kind of practitioner myself, but I think if I'm spending time on this, and this, I'm spending less time on talking to them about the Mediterranean diet, helping them. What is it gonna take for you to exercise 30 minutes, 5 days a week? We only have so much time to talk about people and so much bandwidth. And so
Mhm.
I feel like, okay, all this is happening, but what's happening to all this over here? Which is the basics, fundamentals, new,
uh, yeah, I feel
it's
like
not as
it's,
seductive. I know. It's not as
uh,
much fun maybe for the practitioner. I know.
yeah, but it kind of goes back to what you said. It's like, when you have to do that kind of risk benefit analysis, and it's like, hey, you know what? You have these major, and just using the IVs as an
Mhm,
example, you have these major nutrient deficiencies. You have some gut health issues. I,
mhm,
in order for me to help you thrive, I want to recommend some IV therapy
mhm,
for this period of time,
mhm.
understanding that, you know what, these bags aren't perfect, but it's not like I'm giving you 1,000 IVs,
Mhm.
also, in that nature as well. And hopefully we're doing things to support your detox pathways at the same
Mhm.
time. So I guess that it's kind of like the balance, right? And so that's the struggle and finding the balance.
Maybe
So
we could do like IV offsets, kinda like carbon offsets.
you gotta figure out something. You gotta figure out something, man, because it's like I got to get into the market of glass IV bottles and glass IV lines, and figure out if that's my role in the world. I may have to take it on. So I want to shift into a little bit about menopause here,
Okay.
because with menopause, and we're not gonna insult the intelligence of the listeners. And obviously, it's when you hit menopause, the hormones go bye bye. Essentially, your testosterone, your estrogen, progesterone, DHEA kind of takes over the testosterone production, the hormone production in some ways, but it's only can do so much from those little
Mhm.
glands. And so when we think about you hit there, and then there's all the world of BHRT and estrogen and the many forms of estrogen replacement and progesterone, whether it be troches or topical pills and testosterone. But that's not the end all be all.
Correct.
There are options to help support menopause naturally and with
Absolutely.
supplementation. So, what are some of the kind of go to options
Okay.
or some of the best supplements for that
Well, I
support?
kinda divide things into this is the Tori Hudson 3-bucket approach to,
Mhm.
menopause decision making around therapeutic interventions. The bucket number 1 is what's their quality of life issues, around perimenopause and menopause? And what are the options to address those quality of life issues? And there's a spectrum of options, and we have to understand what are their quality of life issues. What is there something that's more dominant than something else? Likely, the most common symptom is vasomotor symptoms: hot flashes, night sweats, sleep disruption, and mood, and vaginal dryness. Those are the top of the list, vasomotor symptom being the super top of the list in terms of frequency. So I want to know what symptoms do they have that I think are related to perimenopause and menopause, and how severe are they, and how long have they had them, of course, and how much do they interfere with their life? I mean, one woman is pissed off and really bothered by her one hot flash a day, and someone else is like, is tolerating much more than that and not too bothered by it. So it's all about her tolerance. So the quality of life bucket determines possible therapeutic interventions from lifestyle to pharmaceuticals. Bucket number 2 is what is her individual risk for the biggies: osteoporosis, cardiovascular disease, Alzheimer's disease, and we can throw in there type 2 diabetes and um, But the big three, what's her risk? Both, that's family history, her personal history, and subjectively and objectively. And then the third bucket is, does she already have something that needs treatment? And that is likely a non-menopause related condition already, and some of them are menopause related, or age related, like osteoporosis, or she might already have signs of Alzheimer's. So these are the three buckets we need to do our subjective and whatever objective assessment is appropriate, and then decide on what's the best strategies that targets, her 1 to 3 buckets. And that's really kind of how I decide.
Okay, gotcha. And so really it's just focusing on whether it be the risk factor, the symptoms, all these things come together to kind
Yeah,
of pick those
what if
supplements.
she might have nothing in bucket number 1, but she might already have osteoporosis. And so then now that we have some decision making about that, or she might have nothing in bucket number 1, but she has a mother with Alzheimer's. We got to get busy on how to reduce her risk of Alzheimer's. And there's the potential role of systemic hormones in all three of these buckets. But we want to do it wisely. I'm not like hormones for everybody. I'm not that person, nor are the Menopause Society and standard of care guidelines of that perspective. So it's when is it safe? When do you get the most benefit and the least risk in terms of initiation of your menopausal hormones? When do you get the most benefit and least risk in terms of duration? And when do you get the most benefit and least risk depending on the delivery and the dose? Those are all the things we need to know about.
So I want to run a scenario by you because every now and then we'll get a patient who has been diagnosed with a ER positive and a PR positive. So for those who are not positioned, estrogen receptor positive, progesterone receptor positive breast cancers. And in these cases, they can't do hormone. It's like that is you're not able to do either progesterone or estrogen. This is not, and then they're being treated for that. And in many cases, when that happens, now they start getting, in some cases, they're getting hot flashes and they could be severe
Yeah.
and they cannot be given hormones. How can those vasomotor symptoms be managed when they can't take hormones?
Well, there's a slew of botanical and nutraceutical options, and we just sort of march through them. And I usually start with black cohosh when it comes to vasomotor symptoms, because that has actually the most data, number one, and the most information on safety in breast cancer patients. So that's where I typically start with vasomotor symptoms, but there's other possibilities for vasomotor symptoms, even kava or pine bark extract, one study on turmeric and hot flashes, one study on valerian and hot flashes. I typically steer away from Siberian rhubarb and maca because those can, ever so slight, but they can affect estrogen levels. So my go-to is black cohosh. But now she might have some other symptoms for which black cohosh is not indicated. Let's talk about vulvovaginal dryness. That is considered safe to use low-dose topical twice a week estrogen. And it's for the purpose of the local phenomenon. And there's some guidelines around that. But the first in terms of whether it's American College of OBGYN or the Menopause Societies, the standard of care is first try moisturizers 3 times a week plus lubricant as needed. If that doesn't work, then here's how to use estrogen safely. But there are some other non-estrogen options. Vitamin E suppositories has some potential benefit and potential adequate benefit. There's and there's a few other things, but I would say vitamin E is the main non-hormonal alternative. But a lot of women, just that moisturizer 3 times a week and lubricant as needed, that helps a whole lot of women.
Good, good. And we were at the AMP conference in Palm Springs, and oh man, I forgot the guy's name, but he actually founded the company that makes Bexwexin, those hydration ovals. Um, I was like, "What?" He's gonna be here. It was kinda cool. But those are
So the
they're
hydration ovals from Bezwecken are estriol,
right,
or
and then
they're
they have some DH
estriol and progesterone, or they're DHEA.
so yeah,
Yeah,
so they are
so
hormonal,
they
so
are,
yeah.
but they are considered safe in breast cancer patients
Okay, gotcha.
because it's like chapstick. It's local. It's not a systemic delivery. And any data that you see on systemic effects, at most, and it's usually with a cream, not a tablet or oval, ever so slight, ever so transient, comes right back down, bump in estrogen.
Gotcha. So, which is a good one too, because I'm glad you kinda brought that up. See, we go tangent all day, and so that actually made me think about this because the theory is like, okay, if you're doing a local application, and I've seen debates both ways, is some of that gonna go systemic?
Well, if you prescribe a vaginal estrogen suppository that you're giving every single day, yes, it will. Or a vulvar cream every single day, yes, it will. There are those of us who do deliver systemic estrogen that way. I don't do that. I don't recommend it. I think it's problematic. There's absolutely no data on endometrial safety for that method. Uh, but if you're treating what's called GSM, which genitourinary syndrome of menopause, which includes vulvar vaginal dryness, it's the twice a week low dose, these tiny, tiny doses of estrogen is the treatment, and that is not a systemic delivery.
Okay, gotcha. All right, this estrogen time. This is like one of the best parts of this right here because let's say you have a female patient and estrogen is indicated. You've looked at the safety of it. We want to go that direction. There's quite a few methods to do it. You have topical, and the topical could be, you can vaginal. There's some pharmacies they do on the, inner thigh, inner arm. Then you got the troches. You have your
Capsules, patches,
patches.
injections,
That's
yeah.
injections, all that. So, is there one that you absolutely stay away from?
I stay away from implants and injections.
Pellets and
And the
injections.
reason
Okay.
why is there's a lack of safety data. Those women who get that delivery, there is data on a higher rate of abnormal uterine bleeding, a higher rate of hyperplasia, a higher rate of hysterectomy. And that's because we don't have the data to show how much progestational agent do you need to give to that woman who has a uterus still. So it's problematic if she has a uterus. I think it's not a safe way to deliver the estrogen. Well, what if she has a hysterectomy? Okay, then I can't argue my point, but I can argue that the lack of flexibility, especially of pellets, you're in or you're out. And I have so much more, and even injections, it's done. It's a done deal until it wears off. I have so much more flexibility with every other delivery method in terms of the dose. I can start, I can stop, I can taper up, I can taper down. So that's what I have to say about that. And I know that you're in Arizona, and I think pellets and injections are pretty popular. And I think, and I would argue, that is not a comfortably safe way to deliver systemic hormones.
I have a couple of female patients who they love the injections. They never, I monitor.
Well,
I
yeah,
keep the
people
dose very
like
low.
crack cocaine too.
This is true. Doesn't mean I got to sell them crack, Dr. Hudson. It doesn't. You like it? I got you. Since you like it so much, you got to get it from somewhere. Might as well be me. You know. So, but I would say with the injections, and the reason when I first, again, the average of the doctors that train us, and I was with some doctors who were about that life, and I'm I the two women I had and they're like the only two that I have not had breakthrough bleeding with. Literally the only two.
Yeah.
And it's just like,
You
yeah, we're
mean the
not doing
only
this.
two
who did not get
On
breakthrough bleeding with the
injections.
right. And I tried cypionate, I
That's a
tried
good
valerate.
example of problem.
And it's like, yeah, we're done with this. And so we have two. And I'm just literally every time I talk to them, like, and then I was like, okay, we also want to make sure we do ultrasounds too, because I
I'm glad you're thinking
don't
that
know.
way, Alex. I mean, Greg, sorry.
It's
I
okay.
think that, you can call me Bob.
This okay.
Um, I think if one is not gonna let go of the idea of pellets and injections, and they have a uterus, I would say you gotta give them a Mirena IUD, uh, and change it out probably every 3 years, because there's just not no that we just don't have the data on endometrial protection for those deliveries. We don't have it on troches either, but we have it on patches and we have it on oral capsules, oral tablets.
Are you are you okay with oral capsules? Any clot?
I am. I mean,
Yeah.
we don't have to give transdermal to everybody. In fact, this is a little known factoid. There is more variability in absorption with creams, gels, and patches than there is with an oral capsule that you swallow. Because there's many things in a day that affect the absorption through the skin. The temperature of the air, how hydrated or not hydrated are they? Alcohol, no alcohol. What else? Time of the day, even. Skin thickness, ethnic status. All those affect absorption through the skin more than oral. So there are women that you definitely don't want to give oral to, like she had a DVT or a stroke. No oral. More migraines with aura. No oral. Has a gallstone. No oral. Has chronic hepatitis, cirrhosis, whatever. No oral. High triglycerides. No oral. Hypertension. Better not to be oral. So there are all the people who really shouldn't take oral, but that doesn't mean everybody should take transdermal.
Okay,
And
gotcha,
and and
gotcha.
again, I think about, okay, those patches. Okay, that's in the landfill.
Mm,
Um,
yeah, gotcha. A lot of different ways. I know. It's like I said, there's no free lunches. There are no
yeah,
free
I'm
lunches,
glad
unfortunately.
that's a good
Uh,
phrase.
unfortunately. So, for our women that are listening right now, what's the one thing they can start doing today to support their hormone health, no matter what stage or age they're in?
Drink less alcohol.
I mean, that's helpful too.
I'm serious, I'm
uh,
serious. Drink
oh yeah.
less alcohol.
Mhm.
I mean, even the what's considered moderate for women at 1 drink a day, that actually does increase still the risk of breast cancer and about 6 other cancers. And
Mhm.
so, in fact, I wrote a blog, I think it's on my blog, about this topic recently. I mean, if I were to really give my best advice, I would say don't drink. Or I would say maybe 1 drink every couple weeks. I mean, a lot of people don't wanna hear that, but I'm basing that on actually scientific, data of what I think is the latest kind. Um, but other things to support hormonal health, I'm just gonna get still really basic. Fiber, adequate fiber in the diet. If you can't get it, take it. Uh, Stress management, stress reduction, minimize exposure to environmental, toxins. Those are really the basics. And I'm not going to just say every woman should take this herb or this nutrient, with the exception of fiber. I might say that, because that has to do with that estrobolome and the microbiome and the detox pathways. And it buys you a lot. It buys you a lot of health benefits for your future.
Yeah, that's where I feel like I've gotten smarter over the last few years is if I think there's some estrogen metabolism kind of dysfunction, you know, just be honest, man. I was like, give them dim it up, turn on the dimmer, and you go with that. But then you realize it's like, well, when you start looking at the three phases of liver detoxification, it's like I can give you all the DIM and glutathione and B vitamins in the world, but if you are fiber deficient and you're not pooping, it's literally not going anywhere. We
Yeah.
have to address the gut health first, and that was just getting more education on
Yeah.
my end. I was like,
Yeah,
wait,
I
I'm
think
missing the boat
fiber
here.
buys you the all 3 phases. I don't think the DIM buys you all 3 phases. I'd have
It's
to
like
look back at that, but
one and a
yeah,
half,
okay.
one and a
One
half,
and a half.
one and a half, one and a half. You're
Alright.
not getting all that you need with that. So, all right. Before I let you get out of here, first of all, I want to say thank you. This has been great. I had to find you at a conference. I was like,
You
wait a minute, I'm
did.
going to this booth, and like, wait,
Well,
we got to do this
I hope I'm
podcast.
not annoying you too much with my
No,
answers to your questions.
no, no, no. I'm not easily annoyed at that, which is a good thing. But no, it's an honor for me to have you here and to pick your brain a little bit and have our listeners learn about you. And I want them to learn more about you and especially about Vitanica because again,
Thank you.
most of my female patients have some type of Vitanica product, whether it's an iron extra or a Femry balance or the women's passage. So many great products that are essential and they're clean and they're great.
Thank you.
And and I'm so happy for you that it's growing and continues to grow. And I don't know how you do it. Like I started working with a supplement company. I'm like, oh my God, this is a lot. This is a lot, but hopefully you guys have got it off the ground and it's going well. But back to the question, how can where can our listeners learn more about you,
Okay.
your book, your company, and all the different
Alright.
programs you're involved with?
Well, thanks for the opportunity for me to say that. So there is
Yeah.
the drtorihudson.com is the blog, and I post things there pretty religiously twice a month. Um, Usually it's some updated research study that I try to simply analyze and make comments on, but sometimes it's a bigger theme. So there's that. There's Vitanica for clinicians. It's VitanicaPro.com. For consumers, it's Vitanica.com. Uh, and then for practitioners, they might be interested in the Institute of Integrative Medicine and Women's Health. And I have quarterly seminars. They're all virtual. We have one coming up early November on menstrual disorders. We're talking about POI and irregular menses and more, abnormal uterine bleeding. So Institute of Women's Health and Integrative Medicine for the quarterly virtual seminars. And then I also have a women's health mentorship, a year-long program that I do with Dr. Jacqueline Smeaton. And we've done one cohort already, and we're getting ready to start a new cohort in January. So that's probably just womenshealthmentorship.com. And there's a couple different levels. That's both clinical and business practice development, professional development. And so those are the main ways. Of course, I have a clinic in Portland, Oregon called A Woman's Time, but we do telemedicine, but you have to have either be an Oregon resident or have an Oregon, address to under your belt.
Okay. All right. Well, I will put all of that in the show notes. So
Thank you,
no one has to
Greg.
they don't have to write furiously and try to keep up with that. And we will put that there. And again, it has been an honor and a pleasure. And we got to do this again because I feel like we just barely scratched the surface. This could be one of those super long
Well,
things. So
I'm sure I could manage to come back again. I appreciate what you're doing, and this is
I know. I wanted you to.
this is
I
great.
wanted to do it.
Your industriousness, your entrepreneurship, your
I'm trying,
desire to
man.
educate. Awesome.
Oh, I appreciate it. And I was trying to get you to come down and do it, but I was like, I think we were trying to do it in the summer, and I think your assistant, she's like, yeah, it ain't happening, bro. Not in the summer. She's not coming to
No,
Phoenix. So
I am
you better
not
do a
coming to
Zoom.
Phoenix in the summer. That is true.
So you better do it on a Zoom or wait till A&P is back in Phoenix or something like
Yeah.
that. And so I didn't want to wait however many years that's going to be. So because they keep picking random cities, because I think we're in Madison, Wisconsin next
Wisconsin
year.
next time
Yeah.
around.
All right. Well, I'll make sure I eat plenty of cheese. And so, but thank you again. Appreciate your time,
All right.
and we'll do this again.
Keep up the great work.
This is Dr. Greg Jones here at the Optimization Academy. Again, I'll put everything about Dr. Hudson in the show notes. I want to thank you all for listening. And until next time, let's stay optimized and let's stay healthy.